Thank you very much for introduction, and I'm really very pleased to be here because I just arrived. So, and I really hope I will be fine with my talk. But before we'll go to SGLT2, I would just like to remind about ejection fraction and actually why it's so much important to talk about ejection fractions. For the decades, ejection fraction is the single most important number in cardiology, especially in a heart failure. But that was proposed in 1962 by Professor Braunwald together with Falls, and actually that was a purpose to describe a method that actually utilizing indicator that it's with precordial detection that permit estimation of the fraction of the left ventricular and diastolic volume ejection per beat. So, is it still relevant or not? Is it? I mean, it's a great indicator, or should we go far away from the ejection fraction, from the number? But because there is a problems with ejection fraction, what kind of? Actually, because ejection fractions tells only a part of the story. Also, the prognostic significance much poorer as ejection fraction goes up. Another thing is that volumetric measures subject of axis measure on echo, load dependent, and you know that it's a very much independent from sonographer, so it's plus minus 7 points in most labs. But the foot is bad and the proportions are too small. I mean, we will never ever find some great solution for prognosis and for treatment. The reason why I decided to raise up the story about ejection fraction is because ejection fraction currently it's defined. I mean, the nomenclature, the number is defined by clinical trials. So if we will see here, so the trials that is going on the left side, it's a trial for heart failure with reduced ejection fractions, and on the right side, it's the trials for the heart failure with preserved ejection fractions, and somewhere in the middle with mid-range ejection fractions. So it's absolutely, it's not a biological cutoff. It's a clinical trials cutoff. Therefore, I mean, heart failure, it's a clinical diagnosis, and we don't need to have this number, the ejection fraction number, to make the diagnosis of heart failure. But, if not only one but, if we will see for the prevalence of a heart failure, and we actually published this paper, we collected all the trials, all the epidemiological studies, and we see that heart failure is very much prevalent. I mean, in Western Europe and United States, and also if we will see to the Southeastern Asian countries. And it's actually very much around 1 to 3%. But what does it mean? So it's around 60 million people in 2019 who are really affected by by heart failure. But when we are saying about a heart failure, we have to define who are the new onset, who is chronic, who is worsening, and who is advancing heart failure. And actually, the meta-analysis that was published 2024 showed us that, and again, there is a huge number of patients, almost 1 million patients with heart failure, and this meta-analysis showed us that actually a chronic heart failure has a much better prognosis compared to new onset and worsening and advanced heart failure. So probably we really need to be focused on these entities compared to maybe number, or should we not? Another thing what is also important is because all the time we're saying that different phenotypes, clinical phenotypes, have a different prognosis. So one of the good studies that actually was published 2017, it's together with the heart failure registry that from the United States showed us that 5-year mortality was absolutely the same for heart failure with reduced ejection fraction and preserved ejection fraction and mid-range ejection fraction. So there is no difference within 5-year mortality. But why? The reason is about the number of signs and symptoms. If the number of signs and symptoms is small, then probably the prognosis will be different. But if the number in HFpEF and HFrEF will be, HFpEF patients will be increased, then the prognosis will be quite similar to HFrEF. Well, in that matter, there is some kind of controversial because the EC heart failure long-term registry showed us that all-cause mortality and heart failure hospitalizations is much higher in patients with heart failure and reduced ejection fractions. So should we really still need this number? Ejection fraction. And actually, I would like to add to this quote that actually we do need, because it's modifying risk in some cases of therapeutic benefit. And now for defining heart failure, we do need several things. It's not just about ejection fractions. Again, we have to have symptoms and signs. We have to have elevated natriuretic peptides or the presence of pulmonary, either systemic congestion. And if we'll go back to the prevalence and to the epidemiological data, then we will see that actually up to 47% it's patients with preserved ejection fractions across the world. And up to 49% it's a heart failure with reduced ejection fractions. And in the mid-range, it's 14% or 14%. But we have a very much economic burden of the heart failure across the world. And now let's go to for their guidelines. And the guidelines tell us that there is four pillars that actually, four pillars which have 1A class of recommendation for patients with heart failure and reduced ejection fractions. And there are ACE inhibitors or RNA, beta blockers, MRAs, and SGLT2 inhibitors. And that comes from their data that gives us from the dapagliflozin and empagliflozin with reduced ejection fractions studies. And we see that there is a very nice reduction in both arms. So the same is for recurrent hospitalizations. There is a 30% reduction for both for dapagliflozin and empagliflozin too. So that is one of the reasons to put their SGLT2 inhibitors for the 1A class of recommendation for heart failure and reduced ejection fractions. Moreover, DAPA-HF study showed that actually, dapagliflozin was efficient on worsening heart failure and mortality. Therefore, when one of the good colleagues of mine, Muthu, together with colleagues, there's a very nice meta-analysis and compared that actually comprehensive therapy compared to conventional therapy will bring us 8.3 years more additional year, free of hospitalizations, free of death. So this is something that really should be taken into account. So what about heart failure mid-range and HFpEF? So in 2021, we really published the guidelines that showed us that actually for HFpEF, the screening for and treatment for etiology and cardiovascular and non-cardiovascular comorbidities are recommended in patients with heart failure and preserved ejection fractions. And the same is for heart failure with mid-range ejection fractions. But unfortunately, 4 hours later, these guidelines were not relevant after their publication, because of the study Emperor Preserved that actually was presented at the same EC Congress 2021. So 4 hours after the guidelines were presented, they were already not relevant. So that's why I'm saying about Emperor Preserved study. So Emperor Preserved that was published and was presented in 2021 showed us a 21% reduction over primary endpoint which included composite of cardiovascular death and heart failure hospitalizations compared to placebo. And the next year, that was a study of DELIVER study that actually is the same, showed us 18% reduction, and the number needed to treat was 32, something quite similar to Emperor Preserved study that showed us again the beneficial effect of SGLT2 inhibitors in patients with preserved ejection fractions. So if we will go a little bit precisely to different studies, for example, Emperor Preserved, the reduction in cardiovascular deaths and heart failure hospitalizations. Well, first, there is a relative risk reduction, 21%. Absolute risk reduction was lower, but the number needed to treat 31. So we see that it's a good number, and that was the first actually positive study for patients with preserved ejection fractions. And actually we will see that the significance that was achieved by SGLT2 inhibitors was on the day number 18. So it's quite efficient treatment for patients with heart failure and preserved ejection fraction. And for the delivery, so it's quite the same number. So if we say about the relative risk reduction, it's 18%, and again, about absolute risk reduction, it's the same number, 3.1, but the number needed to treat, again, it's quite similar. We're talking about a class effect. And if we will see here, so the statistical significance was on the day number 13 of the dapagliflozin to patients and to the effect for cardiovascular death and heart failure hospitalization. And once again, what's important that we are talking about class effects. So delivery and EMPEROR-preserved meta-analysis showed that it is consistent reduction in both components for primary endpoints. So this is something important. This is something crucial that actually brings us non-relevant guidelines 4 hours later of their presentation. What is also important, and I already emphasized about worsening of a heart failure and or new onset heart failure, that we need to focus on that matter too. So the SOLAIST worsening heart failure studies, the primary outcomes, they were all patients with type 2 diabetes but hospitalized for heart failure or within 3 days of discharge. Again, they showed the consistent benefit with the therapy with sotagliflozin compared to placebo. And this is something very crucial because there is something that we really can focus on. And the patients here, it wasn't important about ejection fraction. Therefore, with empagliflozin, they just decided to, again, to see that maybe it was just for SOLAIST study for sotagliflozin, but not. It also was true for empagliflozin. So again, acute heart failure stabilized patients, either to empagliflozin or to placebo that were randomized. And one, again, primary endpoint is a clinical benefit about death, number of heart failure hospitalizations, events, time to first heart failure event, and change for quality of life. Because quality of life here in patients with heart failure and preserved ejection fractions is very, very important. So the IMPULSE study, and I just would like to show you here the inclusion and exclusion criteria, but not going into the detail, showed that actually the result was in 30% greater likelihood of clinical benefit with empagliflozin compared to placebo for all-cause mortality and for heart failure event. And actually that was consistent regardless of heart failure onset, so it's important. So if it's a new heart failure onset, we don't need to wait. We have to start as early as we can. If it's a patient either with reduced ejection fraction or preserved ejection fraction, we should start as early as we can. And again, it doesn't matter without or with diabetes, type 2 diabetes mellitus. So that was for treatment effect and for clinical benefit at day number 19. But I would just like to show you that actually that is a unique molecule that showed the consistency across the whole ejection fractions. If you will see down, in a down row, RB, ARNI, MRAs, and digitalis didn't show that such kind of result, such kind of fact. Only SGLT2 inhibitors showed, if we will see for dapagliflozin and for empagliflozin, showed that these are very much relevant for across the whole spectrum of ejection fraction. And one more publication that was published while I was traveling, it was published 19th of September, and together with my colleagues from Heart Failure Association, we put, we organized a statement on SGLT2 inhibitors for prevention and treatment of a heart failure. So here we decided to show all the studies that actually somehow align with our heart failure. And you will see upstairs, there are type 2 diabetes studies that actually first were designed for type 2 diabetes patients, but at the same time they showed the benefit for heart failure patients. And the down, we emphasized all studies for dapagliflozin and empagliflozin, including patients with worsening of a heart failure. So if we will say that SGLT2 inhibitors are not only good for across the whole spectrum of ejection fraction, but also for prevention and patients of risk for heart failure development. So this is something very nice and very important. So we also can use SGLT2 inhibitors for heart failure prevention. And if we will go to the guidelines as the updates for 2023, and I mean 2 years after the first guidelines were published, so the guidelines were already changed because first, for heart failure and mildly reduced ejection fraction, SGLT2 inhibitors is recommended in patients with HFrEF and BREF to reduce the risk of heart failure, hospitalization, or cardiovascular death. And the same was 1A class of recommendation for heart failure with preserved ejection fraction. So there is not only treatment for etiology, cardiovascular and non-cardiovascular comorbidities, but it's also for 1 class A for SGLT2 inhibitors. So this is, once again, an update that I would like to emphasize. And therefore, I would just like to show you that the treatment of a heart failure across the whole spectrum of ejection fractions. So it's still ICD we are saying about heart failure and reduced ejection fractions, in some cases up to mid-range. If we're saying about CRT, it's quite the same, so less than 50%. Beta blockers, it's still only for patients with heart failure and reduced ejection fraction. The same for ACE inhibitors and RB. If we're saying about ARNIs, and we have to say about their patients with ejection fraction below normal, MRA is quite the same because of a TOPCAT study, and we hopefully will see a benefit result furthermore. And SGLT2 inhibitors, they are really treatment across the whole spectrum of ejection fraction. Thank you very much for your attention.